Guys, I'm going to get you to have a bash at the first 2 questions, and then we might debrief those with a bit of prac. More specifically, what I'd like to do is just to reinforce neuromuscular, and in particular muscle spindles. We might do a Pmf stretch over here on somebody that has very tight hamstrings, and I'm going to look at the males amongst us to be a volunteer for that one, for tight hammies, and I'll show you how you can kind of deactivate the muscle spindle through a Pmf stretch. And then we're going to have a play with this little thing, which is a heart rate variability sensor to pick up HRV that we use a lot with our fatigue patients. And it's also used for athletes as well to determine readiness to train. And I think this will help illustrate the difference between sympathetic and parasympathetic as that branch of the nervous system. So have a crack at those first 2 for me, then we'll overlay that with some prac. All right, let's talk about the 3 divisions. What's the first one you've got? Somatic. Second. And the third, which we don't really worry about, enteric. I'll just put it over here out of the way. Anyone come up with something different? There's a few different names for the same systems, but... All right, talk to me about somatic. What are the functions broadly before we split it into its subtypes of the somatic nervous system? So what does this do? Control skeletal muscle, good. Is this a voluntary or an involuntary system? It's voluntary, so we know that that means it's under conscious control. Now, what are the 2 branches of the somatic nervous system? Nice. So what does the sympathetic branch do? What is it responsible for? Flight or fight? Yep. So extend that a little bit more for me. What does that actually mean? So what sort of physiological responses are involved with this flight or fight response? So heart rate goes up, yep. What else? Sorry? Yep, so dilation of blood vessels and pupils. Yep. Sorry? Yep, so BP goes up. What, which one? Systolic or diastolic? Systolic, yep. Diastolic will nudge up a little bit, but in response to sympathetic hormones, it's normally the systolic that cranks up. What about increase in respiratory rate? Increase in sweat rate? So this is essentially the body preparing us to release large amounts of energy. What hormones, what endocrine function results in these? Yep, so adrenaline. Is the main hormone that is responsible for those physiological presentations. So that's flight or fight. What about parasympathetic? Sorry? Rest and digest, also known as coffee and cognac, is how my lecturer presented it to me many years ago. So it's the exact opposite. So it's designed to crank us down. So just do the polar opposite of all these physiological effects. So lowers heart rate, lowers respiration rate, lowers sweat rate, etc. Coffee and cognac is a bit of a traditional term. It's where after a big meal, you know, you retire to the lounge in front of the fire where you sit and have a cigar and have a cognac and just chill out, almost fall asleep. So what hormone's responsible for this down regulation, this impact of the parasympathetic nervous system? Cats can do both. Catecholamines broadly do that and that. So you're right. Now, I want to show you something about this. What's really important, I want to talk about heart rate variability in a second because I think that gives this context. But before I do, let's just pick apart the autonomic nervous system very quickly, and then we'll come back to this sympathetic, parasympathetic, because as a exercise scientist, as an exercise physiologist, as a physiotherapist, you're going to be mucking around. You can have an influence over these things more so than this stuff. But just briefly, tell me about the autonomic nervous system. So what does it do? Go back up to this type of level. So it is responsible for, yeah, so it is involuntary. It is not under conscious control. So the types of target organs or glands that this branch of the PNS is responsible for would include visceral, yep. Cardiac, visceral also interchangeable with smooth muscle tissue, so non-striated tissue. Anything else you need to tell me about the autonomic? That'll do, hey? Let's focus more up here. So I liken this to a gearbox is the analogy I use, particularly with fatigue-related clients. So clients that present with things like chronic fatigue, post-viral fatigue, Ross River, cancer-related fatigue. One of the things we try and test is their functioning of sympathetic versus parasympathetic. And do they have the ability, say homeostasis is here, can they crank up when they need to, activating their sympathetic nervous system or the sympathetic branch, and can they crank down when they need to? Do they have flexibility around their somatic nervous system? Does this make sense? What happens with people in chronic fatigue or states of chronic fatigue, they remain upregulated for extended periods of time. So sympathetic, they spend a lot of time above this line, right? So they're almost always living. They might be spending 80% of their time in a state of heightened awareness. Now, is that sustainable or is that a positive thing long term? Obviously not. We need to help people to be able to crank back down when they need to. They need good flexibility to go between the two because different situations have different needs. Now, have you covered or have you spoken about heart rate variability before? No? So if you look at an ECG curve, this is going to test my... So you've got your P, Q, R, S, T. You guys covered this? Is that okay? I haven't looked at this for about 15 years. And then we follow, so from R to R interval. So if we have another one, bumps up there. So the gap between R waves is what we're measuring with heart rate variability. Now this changes from inhalation to exhalation. So usually when we breathe in, our heart rate cranks up a little bit. And when we exhale, parasympathetic comes in and our heart rate drops slightly. So that's good heart rate variability. We can crank up or down when we need to. Poor heart rate variability or a low score means that we don't crank down as much. We kind of stay up here when we're breathing in, and when we're breathing out, we can't shift back a gear. And obviously, when this is firing, all of these physiological effects are happening for extended periods of time. No wonder people get fatigued. So Chris, your head of school, introduced me to this technology years ago. He was using it with the Titans. And they would record this on their app on their phone each morning and bring their result to training. And Chris would then look at that result as the performance coordinator and make a decision on what load that athlete was to be placed under that day according to their heart rate variability, which was one marker of recovery. So if their HRV is poor, they're partially recovered, then you add a significant amount of load to that athlete in that state, then the risk of overtraining, burnout and injury obviously goes up. So that person might go to plan B, which might include, you know, passive recovery therapies or physio or massage or whatever. If they come in and they show a high HRV, it means they're well recovered from that nervous system perspective and they're ready to go. So they'll do as per planned. So I just want to show you, my apologies, I couldn't get my phone to mirror up here, how this works. So you can actually hop up and gather around if you like so you can see. Who wants to do it? Who wants their HRV measured? Yep, beautiful. So I'll just show you first. There are a couple of different ways to measure HRV. This obviously uses a finger sensor. This is one we've just started experimenting with called CoreSense from the US. Previously, we've used one called iThlete, which is from the UK, and they also have a chest strap that you can use as well. But essentially with this, all we do is open the app and we're going to do a morning readiness reading. I'm going to have to delete my previous entry. So what you'll do is place your index finger in here until you feel a little ridge and then pull back a little bit. Yep. Just until, yeah, there you go. See how the blue light's flashing? Just leave it in there. And then all that happens is you breathe deeply for 2 minutes. And I'm just going to delete the one I did this morning. There we go. Bin, okay. All right, so now it's just going to go through and check the pulse. Yep. All right, so now it's going to record heart rate here and heart rate variability here. All right, so It'll go through a period of time where it just normalizes. So it's going to start recording in about 7 seconds. You know, I mentioned the RR interval over there. So you can see that here. So essentially with HRV, the higher the score, the better. With resting heart rate, the lower the score, the better. So you can see, oh, it's nice, humming along at low 50s. And then we just let that do its thing for 2 minutes. Now with clients, we'll often use this sort of technology. So we'll ask insurers to buy this, and then we'll get clients to take this every morning. And then I'll often give them a plan A and a plan B, just like the athletes at the Titans. And if it shows a HRV above, you know, and you'll see it uses like a traffic light system. If they're in the green, then they'll do plan A. If they're in the amber or red, they'll do plan B. And it's a good way of capturing dose response. So give them a dose of activity, measure HRV the next day, and that's an indication of what that session and the previous day's activity cost them from a neural recovery perspective. It's looking way better than my score this morning. And usually we do this when the person first wakes up, because things like caffeine and daily movement will influence this. So I usually say to clients, get out of bed, do what you've got to do first thing in the morning, and then come back and sit down on the side of the bed, put your hand on the bedside table, you need a firm surface, and then take this recording. And sometimes I'll get them just to take a screenshot and text it to me, and then I'll look at it and go, right, this is what I want you to do today. All right. Finish. This is where you add a tag about how you're feeling from a mood perspective. And then we save. You can take your finger out now. And here you can see your yellow. So see how it's like a set of scales? So parasympathetic on the right and sympathetic on the left. So you can kind of look at that. And if you're in the green, which you're nearly in the green, all right, so you'd say, yep, you're good to go. Here, you're a little bit sympathetic, which means your adrenaline's up just a touch more than normal. So what did you do yesterday out of interest's sake? Did you train yesterday? What was your physical activity pattern like?
What do you mean?
What did you do for training?
I taught a class and then I trained whole body.
Yep. Was that AM and PM or both PM? Both AM. Okay. So that shows that in addition to everything else you did yesterday, you're partially recovered. And then you can kind of see how you're trending over time, which is quite nice. So you can see how you're going for that week, for that month. Yeah, you can get some nice data to draw conclusions from, and then we'll often do screenshots of that and send it to insurers and say, hey, you've paid for this technology. Here's where the person started and here's where they finished as a result of our intervention. And oftentimes it's not so much about formal training sessions, it's about activity pacing and scheduling. So I'll give you one example. This is a gentleman with Ross River. And it's a really interesting case because when he gets really fatigued, he stutters. And when you're having a conversation with him and he talks for an extended period of time, he loves to talk, this bloke. He's a miner. And then after about 2 minutes of continuous talking, his speech quality goes down the tube. And then you look at his heart rate, because I put this on him, and his heart rate bumps up to between 90 and 100. So you can see he's cranking up a gear. His sympathetic nervous system is really going haywire. So all we do for him, or all we did for him, he's got a walking program. And I was showing Kurt this app before. It's called Living Well, and it's got like a breathing timer on it. So you just choose how many breaths per minute and press start. You can see, just follow what's happening with the lungs. So it's inhalation with the lungs filling and exhalation with the lungs emptying. And for him, 6 breaths per minute is working, and I'll just look at his wrist, at the heart rate, and see when he can crank himself back down to his resting, which is around 70, 75. And he's not allowed to talk, because talking cranks up his sympathetic nervous system. Makes sense? So from a walking perspective, which is where he's at after about, God, it must be over 6 months now, we've just got him to be able to walk for like 4 minutes. Then he hits up around 100, and then we stop, do this, crank back down to 70. When he's at 70, we can go again. And we're just up to doing that for 4 repeats to try and get that adaptation. So in dealing with people with this elevated sympathetic nervous system, there's a couple of different stages. And I'm going to say that there are 3 stages that I tend to use with these clients. The first stage is activity smoothing. So fatigue patients, and you'll notice this with athletes as well, they will follow a boom or bust pattern of activity. So if you have chronic fatigue, if you have Ross River, you wake up most mornings and you'll say, what's your self-rated energy? And they'll say, oh, I'm about a 3 out of 10. It's through the floor, right? They'll wake up one morning and go, oh, I'm a 5. So what do you think they do after they self-rate a 5 out of 10? Yeah, exactly. So they go, right, I've got to get this, and this done because I'm feeling better and I don't know how long it's going to last. So they go gangbusters. It's what we call a booming activity pattern. So they go crazy and they do this. Usually it's stuff around the house, right? So they go, right, I'm going to mow the lawn, I'm going to hang the washing out, I'm going to go to the shops, I'm going to get all these jobs done that I've been holding off because I'm fatigued. Then what do you think happens? Usually later that day or the next day. They drop through the floor, they bust. And that can last up to 3 days. So they have to repay the debt that they've incurred here. Okay. And they can tend to spin around in that pattern for a long time. So they might be in bed for 2 or 3 days after half a day's activity. And then they're back to a 1 or a 2 out of 10. And then they'll slowly start to come back. And then one day they're a 5 again. And guess what they do? And they just follow that pattern. So the first thing we try and do is smooth that activity pattern. And we might say to them, we'll use Fitbits or Polars or Garmin's or some kind of activity tracker. And we might give them a specific target and say, right, you're allowed to do 2,000 steps in the morning and 2,000 steps in the afternoon. And you've got to try and spread it out. So don't use everything in the tank all at once. And we try and give them task rotation as well. And I usually break it into 3 categories. I'll say, right, tell me all the physical stuff you need to do. Tell me all the cognitive things you need to do. And then let's brainstorm some relaxation strategies as well. Case in point, physical. This guy with Ross River loves to do some work on his boat in the shed. So that would be a physically demanding task for him. Cognitive, well, he's preparing to get his boat license. So he's got to study. So reading the rules and all that sort of stuff, that's part of his cognitive. Relaxation might be meditation, mindfulness, progressive muscle relaxation, listening to music, anything like that. So we'll put together a routine with the patient and say, right, well, let's try this sequence. Work on your boat for 20 minutes. Then we might try reading your book for 20 minutes. And then we might spend 10 minutes doing a progressive muscle relaxation. Can you see how we're trying to rotate tasks and then avoiding the boom and bust? Where he'll go physical, boom, crash. And then we might say, well, you're going to do that sequence in the morning and you're going to repeat it again in the afternoon. He might get through that 2 or 3 times in the morning and then repeat that pattern, just to try and avoid this boom and bust pattern. Does that make sense? So that's how you try and manipulate sympathetic and parasympathetic nervous system to get back that flexibility to go between the two. All good? All right. Any questions with regards to that? Second thing we do, so activity smoothing, then we do graded exercise program, graded exercise therapy, which is the intervals I was telling you about. So once we've smoothed their activity patterns and they're not booming and busting, we'll go, right. And I usually use walking, but it's what the client likes to do. But most often, because they're doing it at home, walking is the easiest. And then we'll generally determine a work to rest ratio that's going to work for them, usually using a heart rate monitor, so we're not overstimulating their sympathetic. And we can teach them how to flex between the two and give them tools to crank back down and activate their parasympathetic. And the breathing app was an example of that. Then the third stage is work/sport conditioning. And that's a very gradual increase in workload over time. Usually using training impulse, TRIMP, training load, it all means the same thing, which is a combination of RPE multiplied by training time. So if you're prescribing a mobility session that goes for 30 minutes, and that's going to be a 3 out of 10 intensity, 3 3s and 9, that has a score or a TRIMP training load of 90. And you'll work out every session for that week, and it might bring you in at 3,500 training load for the week. And then you might say to that person, all right, we're going to increase by no more than, say, 10%. So that's week 1. Increase by 10% for week 2. Make sense? And then gradually increasing. You've got to nurse them up. They can't handle rapid improvements in training load, or rapid increases rather in training load. Happy with that? All right, let's now focus on, I just want to make sure we sort of capture, get that out of the way, the massage table. Necessity is the mother of invention. That's better. Get all this stuff out of the way. All right, muscle spindles. Where are they based? Where are they located? Sorry? In the parallel to the muscle fibers, in the muscle belly. Exactly right. What do spindles do for us? They protect us from too much stretch of the tissue. Yep. So when you're stretching your hamstrings, what does that feel like and look like when the muscle spindles are trying to stop you from rupturing the tissue? The hamstring normally starts shaking, yeah? Particularly blokes will have felt what that's like. All right, so let's do a bit of a Pmf demo, and I'll show you what that looks like when the spindles are doing their thing, and then you can do this on each other. All right, let's make it a bit practical. So I need a volunteer, please, and everybody else can kind of gather round. Proprioceptive. Who knows the second and third terms? Neuromuscular facilitation. Yep. Contract, relax, normally. Head up this end on your back. On your back, your other back. Yep, that's it. Your hamstrings tight. Oh, what are you talking about? This is good. Look straight to 90. What's going on? So normally when we crank right up, I'm sort of this side so you can kind of see. I might have to get around the other side. And I'm using the apprehension test, right? So I'm looking at his face. So it's not too bad, but generally, you know, you see this twitch and that is the muscle spindle firing, and it's sending a signal to where? To the spinal column, to the spinal cord via what type of nerve would go from the muscle spindle to the spinal cord? Would that be a sensory nerve or a motor nerve? It's a sensory, yep, because there's sensory input coming from the belly of the muscle. And then that signal, if we're talking about a reflex, it stops there, doesn't go up to the brain. So it's recognized as a priority at the lower levels of the spinal cord. Then what happens when we've got like a stretch reflex? So the spindle's fired, message goes up the sensory nerve to the spinal cord. Spinal cords recognize this as a priority. Then what happens? Sorry? So yeah, the nerve plexus. So we've got a nerve plexus down here. So one of the nerves that's activated might be in that plexus, in the sacral plexus or the lumbar plexus. But there's a message sent back via the motor nerve. And what's the target muscle of that motor nerve? It's going back to the hamstring. And what is the impact of that motor nerve signal? What does it do? Contracts it, exactly. So it contracts the hamstring. And when we contract the hamstring from a point of stretch, what happens? It shortens to protect the tissue from tearing from overstretch. Does that make sense? All right, so I'm going to get you to do this in partners in a second. But if we go into stretch, the spindle is going to go, no, I don't like this. And it's going to activate. What is going on? The only bloke in history to have a hip flexion range of more than 90. Is that okay? Yeah. And then the signal is coming from the muscle spindle via what nerve again? Muscle spindle to the CNS is the sensory, recognized as a priority so it doesn't go to the brain. Message comes back via the motor to where? To the hamstring, telling the hamstring to contract and protect from overstretch. All right, I might give the other one a go. So, to desensitize the muscle spindle, we can do something called Pmf stretching. This works well with clients with low back pain and they're hypertonic around the hamstrings as well as the erector spinae and quadratus lumborum. So this is one way of doing a Pmf stretch, all right? So I take the client into a point of stretch. Did you come up here just to show off your hip flexion range?
You feel a little bit, yeah.
Okay, you can feel a little bit. Yeah. All right, what I want you to do is to push into my shoulder with your leg and contract your hamstring for 1, 2, 3, 4, 5. Relax. Feel it there? He's moving his other leg, is he? Okay, push again. Push into my palm. Push down. 1, 2, 3, 4, 5. Relax. Go. 1, 2, 3, 4, 5. Relax. See, I can go further each time. Now he's getting a bit of the shake. So we're trying to desensitize his spindle, right? So his spindle is saying, no, 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 contract, contract. And we're like, no, don't contract. And it takes a while for the spindle to work out, no, I can actually relax. There's no risk of damage. Okay, one more time. Push. 1, 2, 3, 4, 5. Last one. So I'm going to take him to that same range. See, now we don't see the shaking. We saw a little bit the time before, but now we don't. So his spindles have said, no, I'm okay with this range. And they've stopped trying to protect him by contracting the hamstring. Okay, relax. The second Pmf technique I'm going to get you to try is where we contract the antagonist. So in other words, you're going to contract the quads instead of the hamstring. So this plays on a process called reciprocal inhibition that you should have covered and know about. Okay, contract your quads for 5, tighten them. 1, 2, 3, 4, 5, relax. Okay, contract your quads. 1. Go now, try. 1, 2, 3, 4, 5, relax. Quads. 1, 2, 3, 4, 5, relax. And so on and so forth. Oh, talk about poor hip mobility. Okay, well done. So what do you think we're trying to do from a reflex perspective when we ask him to contract the quads? I mentioned reciprocal inhibition. Talk to me about that.
So that it's like okay, comfortable to increase the quads.
You're 90% there. So what happens in that instance with the second type of stretching is one motor signal comes to the quads saying contract and fire, and reciprocal inhibition means that muscles operate in pairs and the opposing muscle, the antagonist, will always relax. So if you contract the quad, what's the hammy got to do? It has to relax. So you'll therefore get more range if you undergo reciprocal inhibition. Reciprocal means pairs. Inhibition means switch off. So it means contract one of the pair and get the other to relax. Make sense? Now the first version, where we contracted the agonist or the hamstring, follows the principle that a muscle will always relax more after it's been contracted. So when I asked him to push down into the palm of my hand, he was activating his hamstring. So you can try both techniques. Any questions? Okay, you've got a few massage tables here. Go have a play. Don't dislocate anyone's hip, please. Just got this right in the way. So where are Golgi tendon organs? Tendons, close. Musculotendinous junction, or MTJ. So where the tendon tapers, or where the muscle, tapers and starts to become the tendon, is often the weakest part in the whole chain. And it's where the majority of muscle strains take place. And it is also where our GTOs are located. So if you think about the structure of a tendon, so you've got the belly. My drawings are terrible, but you'll get the idea. So there's our striations, and then it kind of tapers off. Right about there is that musculotendinous junction where the GTOs sit. And they sit, I think they're also parallel like the spindles to the fibres, and they send signals via the what nerve? sensory nerve this way to the spinal cord again. That signal is interpreted. So this is what we call integration. Recognizes it as a priority and it sends a message back to where? Let's assume that this is the bicep and we're doing a bicep curl. All right, so remember the GTOs monitor contraction as opposed to stretch. So the message comes back to where? The belly. So here's the direction of signal. So if that's a sensory nerve, this one must be the motor. And what happens here? So what is that signal doing to the belly of the muscle? It's getting it to relax. Exactly. So from a practical perspective, if we load up with 50 kilos and we're doing our curl and it's about to rupture, the GTO goes, no, I don't like this, sends a signal. The spinal cord sends a signal back saying, get the heck out of there, and we drop the weight. Now, through resistance training, we're aiming to kind of desensitize those GTOs so we can train at a higher and higher intensity. So the GTOs are still going to kick in, but they have like a memory. So they recognize that, yeah, you've done 50 kilos before, that's okay, that's okay, that's okay. And it generally allows us to go closer and closer to our genetic ceiling. That's the whole idea of training, is progressive overload to get to maximum strength. Make sense? Any other questions, thoughts, comments? There are a third type of receptor that we can talk about, joint kinesthetic receptors that sit in and around ligaments. Did you talk about those? Usually get trashed when we do, you know, for example, in the knee, you've got your medial collateral and your lateral collateral on the inside and outside that give the knee joint integrity. So if you rupture those fibers in the ligament, you'll also rupture those joint receptors that provide info to the central nervous system about where the joint is in space. So this is why we do balance board work as part of ankle, knee ligament damage, to build up those proprioceptors, those joint kinesthetic receptors. All right, let's finish with this. All or none. You should be able to explain that fairly simply to me. What's the all or none principle with regards to motor unit recruitment?
If the stimulus is of threshold value, all muscles of motor unit will contract.
All muscle fibers in a motor unit will contract fully. Yep, don't say muscles, replace it with muscle fibers. So a motor unit is a motor nerve and a certain number of fibers that it stimulates, agreed? Can motor units be different in terms of size? Number of motor units that they activate? Definitely. So if you're talking about really fine motor control movements of the eye, is one motor nerve going to activate less or more fibers if we need lots of precision and control? Less. What about the quads, which are major force producing muscles? We would have more fibers that are activated by one motor nerve, up into the thousands. So generally speaking, more gross motor skill that requires larger force production. Motor units are larger in size, meaning they have more fibers, where more fine motor skills required, and generally one motor nerve will activate fewer muscle fibers. But what you've said is exactly right. When an action potential travels down a motor nerve and activates a motor unit, all of the fibers that nerve stimulates will fire 100% or not at all. So there's a threshold or a voltage that action potential needs to reach in order to trigger that contraction. So how then do we get graded muscle contractions whereby if we pick up a 5 kilo dumbbell and we can also pick up a 20 kilo dumbbell? Why doesn't the whole muscle fire when we pick up the 5? Because the body, the nervous system will only recruit the motor units that are needed to do that job. So if we're picking up the 5 kilo dumbbell, it might only recruit 20% of the motor units in the bicep. But those motor units fire fully. Does that make sense? That's the all or none principle. All right. 2 o'clock, let's have a break and head up to the lab.